So again, Lisa Silverman, we are here for the future of data and how data matters for digital health, the future of digital health. We've got some fantastic partners here. It's been a real pleasure to work with all of them. From URAC, you'll hear from our president and CEO, Dr. Sean Griffin. From CTeL, you'll hear from Christa Natoli. She's their executive director. Over at AbleTo, we've got Sarah Gaffey, who's the vice president of clinical services. And then we have Matthew Rumbaugh from Gateway Rehab. He's their director of telehealth. Excellent. I love seeing the claps there. Yeah, it's been a great group to work with. These are some really professional people who know their stuff, and I'm so excited to bring them to you today. So Sean, I'm going to go off camera and let you share a little bit about URAC and about what we do, and just tell me when you want me to advance your slides.
Okay, I appreciate it, Lisa. And it would not be a webinar with me if I didn't say something about the weather here in DC. It's kind of a gray and cloudy day. Lisa always teases me about it, always saying it's a nice afternoon here in DC. So URAC is no longer the Utilization Review Accreditation Commission. We are URAC, and we've been doing this for about 35 years. We are one of the largest independent healthcare accreditors. We believe in accreditation as a higher standard. We think that very often regulation sets the bar for safety, but there is a higher level. When I was practicing as a physician, I was board certified. That was more than just being licensed. And we think that the URAC Gold Star indicates that your organization is doing something above and beyond the minimum. We work with a lot of different organizations. If you look here on the slide, we've got National Minority Quality Forum. We partnered with them on doing our health equity program, which is outstanding. Our Blue Cross Blue Shield Association sits on our board. The AMA sits on our board. We've had OPM advise us on various programs as we build them. We really think that we are that place where a lot of different stakeholders come around the table and they create programs and help us to create programs where we set a higher bar, where people can trust it more. To my generation, I'd say it was the old good housekeeping seal of approval. To younger people, maybe it's a bunch of 5-star reviews, but it really is sort of more than just the minimum. And a lot of organizations say that working with URAC helped them to do a better job of caring for their community, and that is our intent. CTeL on this slide, we work with CTeL. If you're interested in this area and you don't belong, or your organization doesn't belong to CTeL, I would encourage you to reach out to take a look at the stuff they do. Krista's going to be on here in a little bit talking about it, but they really do a very nice job of keeping an eye on the policy work, on the research going on. I participate in some of their committees, and they're just a great resource as we look at these things. So really excited to be here as URAC to be convening you and to be bringing some of our friends around the table to talk about this. So go ahead, next slide, Lisa. So URAC's digital health programs, we have a number of digital health programs. We were doing telehealth before telehealth was cool. We started back in the late 2010s with telehealth. We're on our 3rd or 4th version of our telehealth standards. We actually talk about telehealth support services where you're doing these stuff around telehealth, but you're not providing the clinicians. Remote patient monitoring, we think, is a great area to continue to expand. We're looking at things like hospital at home. We're looking at websites. We're doing health content provider certification. So we've been doing this for a while. Other people have just sort of discovered that telehealth existed during the pandemic. But if you really want to go with the people who know the territory, you're going to take a look at URAC and what we do. We also have 2 new programs. They've been about 6 months now, health equity, mental health at work. Those are fantastic, groundbreaking programs. I would encourage you to take a look at them. If you touch anything upon health equity and the delivery of healthcare, health equity should be for you. And mental health at work is for everybody, for every employer, anybody who's taking care of team members and who wants their employees to have the best place to work. Take a look at our mental health at work program and take a look at some of our archived webinars where we talk about that. Next slide, please. So thrilled to have Christa come on here, Christa Natoli. She is the executive director of CTeL. She's going to talk about a policy perspective. Christa is a wonderful resource. CTeL is a wonderful resource. Sign up for it. I get no commission on this, but just they could use more members because you will be a better organization if you pay attention to what they're doing. So with that, I see Christa has turned on her camera, and I will turn it over to her to go through her slides. Christa.
Thank you, Sean, for such a kind introduction and all those wonderful words. I'll try to live up to that. My name is Christa Natoli. I'm CTeL's executive director. CTeL is a 501c3 nonprofit research institute. We focus on all the laws, policies, and regulations impacting the delivery of virtual care. We have 3 subject matters that fall under the CTeL umbrella. And the first is telehealth, which is point-in-time care. The second is remote monitoring, which includes remote physiological, remote therapeutics, and tele-ICU. And then the third is AI. But as Sean said, all of these specific buckets, they mushroom out. And there's issues like hospital at home that we need to look at, and robotics, and the list goes on. And so CTeL really is a resource for any policy regulations that are impacting the delivery of virtual care. We are not a trade association, and we are not a lobby institute. We are a research institute at our heart. So we present research to members of Congress and the administration, usually at their request, and we also present it to those that are in the private sector. Next slide. So this is just a little bit about CTeL's hierarchy, how long we've been around, but I think we could probably go to the next slide. If you're interested in how CTeL presents its research findings to the community, we produce two types of research. We produce policy research, which are in the form of 50-state surveys. So you can see those there in front of you. We're very visually oriented. We understand that most of you do not have time to read a 50-state survey. If you are, the goal of probably looking at one of these documents is, how do I get my team compliant? How do I make sure we reduce risk and liability? And so each of our reports includes an executive summary, an FAQ, and is accompanied with a PowerPoint. So if you need to put in any of our research into your existing materials to have a conversation with senior leadership, we make it really easy for you. So that's on the side of like, where does the law stand right now at the state or federal level? CTeL also does academic research. About 5.5 years ago, we started a study looking at the cost impact of telemedicine on Medicare and Medicaid. And that was for purposes of looking at if it made sense to remove originating site barriers. That fell into 1834M. Very serendipitously, that research was important during COVID, and we were the only organization to actually have academic peer-reviewed research. And so CTeL was able to eventually hand over that research to Congress and to the administration at the end of 2022, when the issues of the public health emergency waivers were being considered, and the idea of flexibilities were being looked at by the Consolidated Appropriations Act. So we're very humbled to be able to be in these types of positions because of our research focus. So let's talk a little bit about the research that CTeL did. I want to give you just a little bit of history to put this into context. So pre-COVID, if any of you could actually think back far enough and remember a period of time where we didn't have to use the word COVID, the telehealth community was really struggling with this obscure line within the Social Security Act called 1834M of the Social Security Act. That required that if a patient was going to be seen in person or virtually, they had to meet certain requirements in order for telehealth to be reimbursable. When I say in person, I mean if the patient was physically to go to an in-person clinic and there was telehealth to come in remotely, or if they were to be seen in some type of other hybrid solution. So there was this requirement that if a practitioner was to receive reimbursement via telehealth under Medicare, that patient had to be located in a rural zip code. That means that even if you are a one-stoplight town like my hometown in Ohio, which we are not considered rural, you still have to put your zip code into the CMS website. The second is that you have to determine where is that patient physically located. If they're located in their home, telehealth is not, Medicare will not reimburse for that telehealth service. They have to be at a hospital or clinic setting. Third is that not all provider types are considered reimbursable under CMS pre-COVID. So there's only a specific group of provider types. And the fourth is that there were only about 144 CPT codes. So this was pre-COVID. Congress actually came up with this idea because there was concern back in 2001 that if telehealth was going to be included into overall healthcare spend, that telehealth was probably going to unnecessarily increase the budget because there was a concern of overutilization. So Congress, with all of its infinite wisdom, said, okay, we have an idea. We're going to purposefully suppress utilization by putting in place these originating site barriers. So that's how those 4 originating site barriers came into place in effort to suppress overutilization by the patients. But what we found is it actually did the opposite. It actually suppressed access to care to patients that actually really needed access to care. And there is data to suggest that it increased catastrophics because these patients weren't able to get access to good quality care in time in a preventative way. So where did we go from here? So CTeL was asked by some stakeholders in Congress, do we have any data that shows that 1834M is that 1834M could just be eliminated now? We could remove those originating site barriers because we had data to show that telehealth was either cost savings or cost neutral. But at the time we didn't. So we engaged on a 3-phase study that took about 5.5 years. And the first phase was a literature review. We did a data dictionary. And then the third phase was a financial assessment where we looked at 1.43 million telehealth encounters that were conducted during the pandemic. And we looked at issues like cost and utilization, services provided, and access. And we were also able to look at very specific patient populations. One of the largest patient populations we were able to look at were mental and behavioral health patients, which we found that if they were able to receive access to care sooner via telehealth, it actually reduced overall cost spend. So this is specifically what we found. Telehealth can generate significant savings. Overall, telemedicine saves costs to both Medicare and Medicaid. Telehealth is not additive, it is substitutive. That is a really big thing that Congress cares about, because anytime that they are looking and creating a new program or creating additional reimbursement, the concern is this going to be an additive spend? What we found is that telehealth is not additive, meaning that a person wouldn't see their doctor in person and then see that same doctor via telehealth or a different doctor via telehealth for the same condition. It's substitutive, meaning that that patient would likely engage with that practitioner via telehealth, and that would be the sole encounter. Telehealth, the other concern that members of Congress had was, is telehealth more fraudulent than in-person care? Our data actually show that that's really an unsubstantiated narrative. Any of the fraud claims that have come about are specifically related to DME, which is durable medical equipment, that has gone on way before telehealth and is just simply uses the internet, but by no means is actually engaging in the act of telehealth, because these fraud scams, the one that they sometimes mislabel as telehealth, there is no establishment with a practitioner-patient relationship. Oftentimes you have a call center out of country that will reach out to Medicare beneficiaries. It's a non-clinician reaching out to a Medicare beneficiary, asking that Medicare beneficiary in almost a baiting format, do you need a medical brace? Of course, you're 70s plus, don't your knees hurt? And in a baiting format, and eventually that Medicare beneficiary gives in, but that is not a practitioner-patient relationship. It doesn't meet the foundation for what is considered to be a telemedical examination. So that's how we can conclude that they are different. And telehealth has been shown to increase access to care to underserved patient populations, patients that wouldn't ordinarily receive care to begin with, and it is very much preventative in nature as well.
Christa, this is Sean, I want to lift something out of what you just said. Because I remember back before the pandemic, there was all this concern about telehealth as this fraud game and all these sort of things. Right. I think, your research and the stuff that you reference in this slide is incredibly important. And saying stuff is telehealth fraud is like saying, I got a phone call from somebody trying to steal my credit card, therefore we should turn off all the phones. I just think that seeing the misuse and the abuse, and worrying about the misuse and the abuse, I think that most people who've had a telehealth interaction will say that it was a wonderful thing and they weren't concerned about it. I think that I just wanted to echo that because that's something that a lot of people get hung up on. Hopefully nobody who's on this webinar thinks that that's a big deal, because the research shows it not to be a big deal. And if anybody brings it up, I think your counter arguments are incredibly important.
Thank you, Sean. And we actually were in such a unique position that during the Trump administration, OIG issued a headline that said telehealth fraud, but the case was specifically for durable medical equipment. We were able to have a very great educational phone call with OIG, and then they reissued a new headline and a new statement, and then also a statement that said that we do not believe that telehealth was involved in this fraud. So it was, a lot of this is just miseducation. You sometimes have people that are very new to the term telehealth or virtual care, and it can be confusing. So a lot of this is not malicious.
Thank you.
So in addition to the research that we did, I want to talk a little bit about the impact of that research. So just to kind of recap and give a timeline, 2001, Congress is looking at the Balanced Budget Act. They're trying to figure out a way to improve access to care to patients, but then also make sure that we are not going over the budget, because that was a really big deal in 2001. There was this idea that telehealth be a way to improve access to care. CBO gives telehealth a score 83% higher than it's actually going to cost the federal government. So Congress comes back saying, okay, we don't want to tell our constituents no to telehealth, because that's not great in terms of policy or in terms of being able to provide care to patients. But we also have this issue of the budget going through the roof, and we have to be mindful of that too. So the compromise is that we were, as Congress, they were going to implement these utilization restrictions to suppress utilization, and that is now known as originating site barriers. Those 4 originating site barriers went away during COVID, and they were officially gone until May 11th of 2023. Now, on May 11th of 2023, Congress knew they had to act because Congress wasn't ready yet to determine if they were going to move forward with permanency of making those waivers flexible and essentially removing the 1834M requirement into perpetuity forever. So what happened was the Consolidated Appropriations Act was passed in 2023, and that allowed for those waivers to be made permanent until December 31st of 2024. So they were able to extend, I guess permanency is probably the wrong word, but they were able to extend until December 31st of 2024, giving Congress time to look at more research to determine if they want to be made permanent or not. That's where we are right now. We have about 6 months for Congress to determine if they want to make these flexibilities permanent through a larger piece of legislation, because they will expire. So what does this mean practically for those on the call? Anybody that is receiving reimbursement under Medicare and for telehealth services, that will officially go away on December 31st of 2024 if you are receiving benefits from those flexibilities. So if you are receiving reimbursement directly into the home, if you are benefiting from the extended provider types, the extended reimbursement codes, that will all go away. And so CTeL, along with the telehealth community in URAC, we're working with stakeholders and policymakers to provide education and research to say, we need to think about what permanency will look like. And there are a couple bills that are in front of us right now in Congress that are doing quite well. One is the CONNECT Act, and one is the Telehealth Modernization Act. These 2 bills will allow us to look towards permanency. So likely they're not going to pass on their own, but they will hopefully be able to pass as some type of larger package. And what is going to be included in that larger package? Because remember, there's 14,000 bills that are introduced in every Congress. 0.01% of those bills pass. So the idea that the CONNECT Act or any of these other telehealth bills are going to pass on their own is very, very slim. So the goal is that the telehealth digital health community, CTeL included, URAC, we work together to show our support for these individual pieces of legislation, and by getting co-sponsors, by calling our members of Congress to say these bills are important to our constituents. And because they have this foundation of support, then members of Congress are more likely to include them in a larger healthcare package at the end. So we've got treats, which is dealing, in addition to Connect, something else that's very important to understand is dealing with treats and the Support Act. Matt Rumbaugh, I don't want to take away anything that you're going to talk about, but Matt is an excellent resource, and he was the one that really educated me on treats and the Support Act. We have to understand that the other flexibility that will also end as of December 31st of 2024 is the DEA flexibility that allows prescribing directly into the home. So because that will also go away as of December 31st, that right now is not in the hands of Congress, it's in the hands of DEA. DEA has to issue its final rule, but Congress is also looking at maybe we could introduce a piece of legislation that will allow DEA, that will allow for the prescribing of controls directly into the home via telehealth and make that permanent. So that's what we see with treats. There's support reauthorization. We're really hoping that the support becomes reauthorized, but both treats, support, and Connect will likely be included into a larger bill. And then our outlier bill is the remote patient monitoring bill. Remote patient monitoring is, as you know, is not telehealth. Telehealth is point-in-time care. Remote patient monitoring is when you engage with the patient for a period of time, usually 16 plus days after they've already seen a provider in person or via telehealth, and you're trying to monitor a chronic condition. That could be diabetes or a heart-related issue, but it's more likely catching a lot of speed with mental and behavioral health for patients that are in rehab facilities or are leaving inpatient care and needing to be monitored to see if they have if they are unfortunately taking these types of controlled substances again that they're not supposed to be taking or taking opioids. And so the idea with these two remote patient monitoring bills is that it would allow for a more focused case study, and then expanding Remote Patient Monitoring Act would allow for the elimination of the 16-day requirement and throw it back to the practitioner to determine how many days are necessary. We also have, so we've talked about Connect. There was a new bill introduced. Connect was introduced by Congressman Mike Thompson from California. It has roughly around 30-some co-sponsors on the House, 60-some co-sponsors on the Senate side. This bill is doing well. We need more co-sponsors on the House side. Buddy Carter from Georgia, Republican, introduced TMA, which is the Telehealth Modernization Act. Doesn't have a lot of support, but this is more of a messaging bill, we think, from Republicans saying, hey, we support telehealth too. We are in support of anything that will move permanency forward. So if you are interested in influencing any of these policies, just be aware that now is game time. I've been in telehealth for, well, at CTeL 16 years, I've been in telehealth for 18 years. I feel like we have been training for this point in time. Right now, we have potential legislation that has to get passed on eliminating originating site barriers, 1834M, and essentially making permanent the flexibilities that were afforded to us during COVID. We've got DEA, the DEA waivers to allow for the prescribing of controlled substances directly into the patient home or at the patient site, which is a big deal because if you talk to any mental or behavioral health provider, they'll say, you know, I could see a patient via telehealth, but I can't treat them if I can't prescribe them the medication. That's a big deal. And then the third piece that we haven't really talked about much here, but is dealing with this issue of high deductible health plans. It specifically deals with reimbursement on the private side. That is also coming to an end as of December 31st of 2024. So we are very much in we are very much in a time where we have to aggressively pursue these bills, because as of January 1, we'll be in a new Congress, and all of these bills that have so much momentum now will go away. And we'll have to start over. But worse is that the flexibilities as of December 31st will be gone. So we'll have to revert back to pre-COVID standards. I want to be mindful of time. Does anyone else have questions?
Chris, I think you're good. And it's a really nice lead in to exactly what Sarah is going to talk about right now. But I encourage people to put questions in the chat box. Michael Gary put in a question. Hi, Michael, of access to care and telehealth access to care. Sarah, I knew you touch on that naturally whenever we speak. And Lauren Hammett from our team chatted in our URAC's white paper on telehealth and access to care.
Thank you so much, Lisa. And Christa, thanks so much. So wonderful and really exciting to hear about all the movement and policy development, especially around continuing access to care for telehealth. So thank you for your time, and thanks for inviting me. Hi, everybody. My name is Sarah Gaffey. I'm the Vice President of Clinical Service Delivery here at AbleTo. I'll spend a few minutes just talking about who we are and what we do. So AbleTo is really one of the first telehealth providers for behavioral health, and we really have been around for close to 15 years and have been delivering remote therapy via video or phone to our patients nationwide. So we are live in all 50 states. And when we talk about and think about access to care, that's been one of our primary drivers, is to really ensure that we can reach people across the country in the most remote areas that otherwise wouldn't have access to really high quality behavioral health care. And so here are some stats on the slide that you see. One of the things that we're very proud of is our provider community or network. And so we're about around 1,600-ish therapists and coaches in our network today, and really focused on building out, again, a very high quality provider community, as well as the care that we provide. And again, we are reaching members and patients across the nation in all 50 states, over 122 million covered lives today, with almost 4 million completed sessions since our inception, which is really exciting. And I've been with the company for 10.5 years now, so have been on the journey to continue to improve access to care. And again, just really excited and humbled to be here with you all today. We can go to the next slide. So just to ensure that everyone really understands the focus and the type of services that AbleTo is providing nationwide. So we do truly cover the spectrum of need, and this has been a journey throughout our time as we've grown from a small company to a larger company. But today, what we really have are 4 very distinct products in order to reach patients across the country with different severity of need. So we'll start here on the left-hand most of the slide with our self-care product. And that's really a digital self-help program that's available 24/7. And you'll see as I go through the slide here that it's really, if we think about it, reading it from left to right, we're serving patients who have low severity of mental health need to the more complex mental health need. And so following self-care, sort of going up the slope there, we have a coaching product specifically. So this is our community of about 450 or so coaches at this time, who are dedicated to providing one-on-one weekly coaching sessions. This is a structured cognitive behavioral therapy digital program. So the patient is accessing not only a coaching session, but also a digital app alongside that, that really supports them through their care journey. And this digital app is actually available to all of our patients through all of our programs. Our programs essentially are based in cognitive behavioral therapy, with some components of dialectical behavioral therapy. So we'll see some mindfulness components within, and very, very excited. In a few months, we actually will be launching our first DBT skills virtual program. So very specific. For those who struggle with emotional regulation, or features of personality disorder. So really excited about that. So going up the slope here, we'll talk about our 2 therapy products that we have today. So Therapy Plus is our, program that are again focused and structured within the CBT model. This is a one-on-one weekly treatment patients receive with a licensed therapist. And again, really structured, time-bound, and utilizing our app within and between sessions to really support their skill development and their growth towards recovery. And then finally, last certainly but not least, our Therapy 360 program, which is built for adults who have comorbid medical and behavioral health concerns. So as an example, our cardiac track or our diabetes track, what we know is that folks with comorbid medical and serious medical concerns, of course, will have comorbid depression, anxiety, or stress. So our program here is really treating the depression, anxiety, or stress that goes hand in hand with these medical comorbidities. And what's really wonderful about this program is that the patient has an opportunity to meet with both a therapist and our behavioral coach. And the 2 disciplines really complement each other really, really nicely in order to support that patient towards their recovery journey. We do, of course, focus heavily on ensuring that all patients have a full discharge plan, wraparound care. And if somebody is not appropriate for our program, you'll see here on the rightmost hand side of the slide, meaning if they have psychotic symptoms, more severe mental illness, severe substance use, as examples, that we would be referring them out into the community or to some of our partner relationships. We can go to the next slide. So we're really here to talk about data, and this is something that, of course, we are a data-driven organization, something that I'm very passionate about, and Heidi and others on the call, of course, are, and many of you in the audience, that's why you're here today. So let's dive right into that. So how do we at AbleTo use data to really drive patient care, quality, organizational strategy? So we are, all of our clinicians are trained to use measurement-based care throughout each of our programs. So as an example, we are utilizing the PHQ-9 or the GAD-7, many other assessments, of course, depending on the patient's specific need. But at our core, those are some of the core assessments that we are using. Our therapists and our coaches are really utilizing that to monitor patient outcomes throughout treatment, to again sort of help the patient move through treatment and to change treatment planning or goal planning as the treatment continues to move forward. We also utilize that data to understand our outcomes at an aggregate level, right? So really important that as an organization, that we are ensuring that we are monitoring outcomes, not just at the specific patient level, but at the population health level as well. We're also using data to drive triaging. So one of the things I mentioned in the previous slide is that if a patient is not appropriate for AbleTo, whether after our intake or throughout, at any point during treatment, that we're utilizing the data that we have in front of us to really triage them to the appropriate level of care. Additionally, we are using and evaluating provider-specific level data. So one of the things that we've built out is that we are able to look at engagement data by patient, and again, at aggregate level, and provide feedback and support to all of the providers in our quality community to ensure that, if a patient isn't engaging, as an example, that we can intervene at the appropriate time and really support those providers. We have a wonderful team of a very strong clinical leadership here who is dedicated to supporting our provider community to ensure that we achieve the outcomes that we expect at AbleTo. And then I'll move over here to the right-hand side of the slide to talk about organizational strategy and how we're really utilizing data to drive our operations, right? So I did already mention how we're utilizing engagement data to support our therapists and coaches. We're also doing that to ensure that we have the right amount of therapists and coaches to meet the patient need, right? So we're nationwide, we're across the nation, we're really focused on filling that gap in care. And we have a team of experts that are dedicated here to making sure that we have data insights, to have the provider community effectively resourced so we can really meet the need of our patients across the country. And then, of course, utilizing these data to report back to our client and our client and health plan partners that we work so closely with, and really continues to hold us accountable to them, to one another, very, very important that we're utilizing all of these type of data to really move the business forward and to ensure that we're meeting patient care expectations. We can move forward. Thank you so much. Great. So I've spoken a little bit about this on the previous slide. And my colleague here who's in the background, Heidi Greenberger, might have some comments about this as well in the chat. But really, we're really using, we are so focused on high quality care here at AbleTo, and really ensuring that that care is backed by these data, by actionable insights. And that starts from the very beginning, from when we are onboarding patients, as well as moving them through their care planning, as well as I mentioned, really moving them through their program and tracking their progress and making sure that we're using measurement-based care, digging deep into, ensuring that providers are supported, that we have scaled quality oversight, and that we have outcomes research to support and back the work that we are doing.
So Sarah, before you hop off camera and before we bring Matt on, I'm going to ask you if you had like one way to tell people, organizations that are just starting to collect data, where do they get started? And just like once, because this can be so overwhelming and we know different organizations are at different points. Where's that one point where they start?
Where do you start? My goodness. I mean, for us, that is a great question. For us, we started to collect data at the very beginning of AbleTo time. And so for us, it's always been sort of, really underscoring the work that we do. And I want to just say too, that we are a URAC accredited organization, and really being part of this team, and I see it as a team, really. We've had great teamwork together with URAC to really become a URAC accredited organization, I think is a big part of that, because that helps hold us accountable. And I recommend that other organizations also do the same, because it helps them to also become accountable truly to, as we're discussing here, these actionable insights. And when we are accredited by an organization like URAC, there are expectations and we hold ourselves accountable to them. We are held accountable to them. And then it helps us all here on this call today hold one another accountable to those actionable data insights as well.
So Sarah, we didn't ask you to say that. We didn't plan
You did
but
not
I
ask me to
so
say
appreciate
that.
you saying that. And Sean's going
It
to take you to
is-
lunch when he sees you.
You did not ask me, and it is an honest insight from me, for sure.
Well, thank you. And Sarah, with that, I'm going to ask Matthew from Gateway Rehab to come on board. And Matt, you're taking us right up until our closing. So you got about 8 minutes or so to take us through to our closing, and you're going to be awesome. I'm going to go off screen.
Okay, well, save me for last. I appreciate it. I would say next slide then. And for those of you that are on the West Coast, I'm sure the coffee and the smoothies are going to keep you going. And for us here on the East Coast, I'm running right up. So first off, I'm Matthew Rumbaugh. I'm the Director of Telehealth over here at Gateway Rehab in Pittsburgh, Pennsylvania. Gateway is a nonprofit association, an organization with about 600 employees, 25 facilities. And within our facilities, we include withdrawal management, inpatient acute and extended care, outpatient transitional housing, halfway housing locations. And we deal with patients who deal with SUD, OUD, AUD, mental health, behavioral health. And prior to the pandemic, organizations like ourselves were probably doing less than 2 to 3% telehealth in this market. And the explosion, I feel like it's back in 2015 when I was back at the University of Mississippi as their executive director of the Telehealth Center for Telehealth, because we were pushed into what are we going to do? Everybody's going inside. And one of the biggest reasons why I came to Gateway and what they were looking for is they saw the value. So today, with the time that I have left to share with you, I'm going to give you a snapshot of what made us really maintain and sustain and take the position of we're going to build an enterprise level here. When I hear people saying, "Oh, we provide telehealth," I ask, "What kind of platform are you using?" I ask, "Are you fully integrated?" I ask, I'm trying to see how it's working. How do you have a native app, patient portal? Do you have an educational portal? Do you have remote monitoring tech flexibilities and access, point in time? And so it's really interesting. So when we come into our space, telehealth is an audio video connection like we're doing today. And that was the way that we had to touch our patients. So back in 2020, when they were thrusted into this, we had 4,100 unduplicated individuals across several different counties, approximately 300 of those counties that fell within the telehealth purview that we figured we were going to have to serve. And you can see it inside of here. So we estimated approximately, once we brought everybody back to go live, 70% of those patients would want to return to in-person over having the ability to have access to telehealth. Well, that estimate was low. And due to the extensions and the prior requirements for in-person that Christa mentioned and hammered out really well, great job today, Christa, and the PA OMSAS guidelines for payment and for utilization of telehealth technology, we saw an average of 1,500 encounters a month during our fiscal year all the way through 2023. Next slide, please. This is pretty impressive. This is an impressive slide. And the stakeholders and the providers that were touched had to deal with our clinical team around MOUD, MAT. We had licensed practitioners, master level therapists for our IOP, OPs. We had our peer support team, and we started to see a trend. So at the end of this year, we did over 29,000 telehealth encounters, and taking it to a whole different level. I'm sharing this with you because that showed the access. But the most important thing here is we build out a hybrid model. We still provide in person. We still know that telehealth isn't for everybody, and it depends on your lower level of care. But thinking of it from an enterprise level, inpatient telehealth metrics are completely different than an outpatient telehealth. Go ahead and go to the next slide, please. So I'm just giving you some snapshots. I'm going to try to get through this in the time that I have. But in our intensive outpatient setting, we have 3 morning IOP groups, 3 night IOP telehealth groups across the organization and across our physical footprint. And we started to see the trend that night IOP telehealth was consistently full. That means we can have up to a said number before we have to bring another provider in it. And we were hiring on additional providers in this space to go for that demand because the patients were seeing the value. Home and community became a part of the recovery. So if you were in lower level of care and you had to have a job and you were restoring balance and you had to check in for your therapies or you had to check in for your med checks, just reducing that stigma and giving them a new front door was exploding. And what I'm showing you is a snapshot of one of my outpatient facilities. If you look across the bottom, now this is a KVI indicator, all right? And what a KVI, stay back there, please. Thank you, Lisa. KVI is key volume indicator. I'm not going to get into our statistics with you, but what I want you to see is this is one location within our counties because we have several counties that we serve. And you can just see how I ran through some stats for it. But look at the IOP telehealth group compared to the in-person, because that's critical. You still have to have in-person. People still need to have a tangible access, and we want to send them in when they need to be around people, but we still have group settings in the telehealth. You'll notice to the far right, 44% of our KVIs were coming from our telehealth groups compared to our 55%. If I would show you a snapshot of pre-pandemic, you would have saw 0 telehealth. Fantastic, and everything that we had to get in place. Let's go to the next slide, show you another snapshot. Here's our outpatient group. Currently, about half of our OPGs, our outpatient groups, were slated to remain in telehealth. We've added 12 additional OPG groups in the last year, and space will be an issue at some of these sites. Well, I put that in there for a reason. Space isn't an issue when we were able to extend it into virtual setting. And you can look at what North Hills was able to do. 75, if you follow that track all the way to the right, 75% of our OPG groups were now being conducted for telehealth. And you're starting to see the engagement, the adherence, and the provider utilization for us to be able to figure out where we want to go. That is a big hit coming in 2023 when it was 0 pre-pandemic. Next slide, please. So now we're building this enterprise telehealth model, a center of excellence, and we're starting to use our data because we look at length of stay, transitions to lower level of care, 30 days, within 30 days if you're readmitted, or 30 days from the day of discharge from an inpatient out to an outpatient setting for additional care. We're seeing bumps and the patients jumping into the telehealth avenue, and then readmission rates coming back within 90 days to start your process all over again. We're seeing dips in that. And the impact from the provider utilization, time saving, travel saving. I can have a provider on the inside at one location for inpatients, since we don't bill for that. They're able to see Erie County, Beaver County, and patients that need to be seen grouped for MAT. So we're really starting to see a huge cost metric around cost efficiency. Enhanced patient outcomes are going through the roof. Expanded access to our rural. We break down all those barriers when home and community can be a part of recovery. And this goes for any chronic condition. We see that they're never too far away. And it's so important because a diabetic compared to somebody suffering from SUD, it's 2 different tracks of your sugars go up and we're watching you by monitoring you. We can intervene. If you slip or fall, or we don't react to our craving predictions or anything that's going on because we're staying connected to you, this could be fatal. And we don't want that. And if anybody on this call doesn't know anybody who's affected by SUD, OUD, AUD, I would be surprised. And if anybody doesn't know somebody who lost somebody with this fentanyl that's on the street, xylene's coming next. It is scary. But I wanted to show you something at that bottom screen there. When it comes to us making decisions from our KVIs, notice Greensburg. I'm showing you a snapshot of 2023, and then I'm showing you a snapshot in 2024. And our fiscal years are off, but notice to the far right, you saw that we were at about 30%, 32% of IOP engagement for the telehealth group. Slide over to the right, and you'll see a dip. We dropped to 12%. We lost the provider. losing that one provider impacted in that location because they were constantly being full. So that makes us make some rational decisions around when we are hiring. And that is really, really something of interest for our providers, because staff retention, staff utilization, and recruitment, when you have a true telehealth platform in place that makes it feel like it's as in person, they gain it. So we saw a dip, but we were able to indicate. So if there was like, wow, our volume was going down, well, we were still hitting 100% of our mark, but we realized that we needed to get that provider into place so that the offering of the telehealth could come into play. I know I was the last guy here.
I know, Matthew, I'm so sorry that you are the last one, but I think that is so true. I'm going to talk while I pull up the next couple of slides. You are at Telehealth Center of Excellence here, and we're going to get links out afterwards to everybody. Behavior change set. Look at people first in 2002. We got up and we went to the bathroom. Now I get up and I scroll through Facebook. This is how our lives are right now.
And you might be doing that while you're in your bathroom. The reason why I put that slide in there is because in 20 years, we've seen a behavioral change that was innate in us. That's the biggest thing about that screen. So thank you. I know I didn't get
said that at an event yesterday. I said, we used to not always have this device like right here. It's like sometimes we just need to put that device down. So I've put up a poll here for people, and I'm about to put up, if you want more info right now, you can scan any of these QR codes for the organizations. Thank you to Matthew, Christa, Sean, and Sarah for joining us today.